Good afternoon, everyone. Welcome to another episode of Between My Therapist and I. I'm joined today by Stephanie Sump, our clinical manager and licensed mental health counselor, and Yalily Smith, our owner and licensed social worker. Today we're going to be talking about patients and their loved ones who become caregivers, and the relationship dynamic between them, and some tips on how to navigate this new relationship.
And I am going to be speaking from the point of view of the caregiver who was once simply a spouse or boyfriend or girlfriend, etc., etc. And Stephanie is going to be speaking from the point of view of the partner who then becomes a patient. So a little bit of background on what this vlog, like kind of the nature of why we're coming up with this vlog. Both Stephanie and I have worked for a long time with clients who either experience chronic illnesses or experience sudden changes in their health, or their mental health prevents them from completing everyday tasks and the kinds of tasks that over time require assistance from someone. Sometimes the person can find help from an outside provider, like a home health aid agency or family member outside of the home, things like that. But more often than not, it ends up falling on the hands of the loved one, whether it's boyfriend, girlfriend, husband, wife, it doesn't matter. Kids. Mm-hmm. Also, you have children who are in the home or who have to move the patient, so the loved one who is now a patient, into the home to take care of them, etc., etc. We're going to be focusing most of the conversation around spouses and significant others and the patient. And just so you guys understand, the term patient will be used to describe one partner, so one side of the relationship, and the term caregiver will be used to describe the other side of the relationship. So we're actually talking about a boyfriend and a girlfriend or a husband and a wife, but we're talking about them as patient and caregiver. And that is one of the reasons why we want to talk about it in that way, is because we want to emphasize how quickly the labels start to shift and the change in the dynamic of their relationships really starts to show in how everything about the relationship is done. Whether it's how you call yourself, how you identify yourself, how you see yourself within the relationship, and all these different things. So to avoid a lot of back and forth, just know when we're talking about patient, we're talking about one of the partners who happens to be sick. And when we talk about caregiver, we're talking about the other partner who happens to be healthy enough to take care of them. So we're gonna jump right in. And of course, Allison will be monitoring our discussion, and she'll be asking questions so that if there's anything that pops up that she thinks would be good to elaborate on for you guys, she'll go ahead and ask away. So, okay, here's my observation. So here's what I have seen. Mm-hmm. And I'm thinking right off the bat, I have like 10 cases right off the bat, like immediately I can see them in my head. So I had a patient who had ALS for many years. He actually lived with ALS for a very long time. Mm-hmm. This person was originally very independent. His wife was very independent. So we're coming from a couple who have a pretty healthy attachment to begin with. Mm-hmm. They were old enough that they were retired. They had things that they like to do together. They had hobbies and things like that. They also had individual projects and things that they had going on for themselves too. Mm-hmm. And on top of that, personality-wise, which is always important to note how that affects everything. Mm-hmm. personality-wise, he was very independent and almost to the point of being a little bit withdrawn, because he was so into his own thing and doing his own thing that sometimes he would be gone for hours and hours and hours, and she was totally cool with that. She's also very independent personality-wise. So then I remember the situation with them, and I remember when the wife became a caregiver. So they get the ALS diagnosis, and when you get a diagnosis, from what I've seen, when you get a diagnosis, whether it's a stroke, ALS, whether it's depression, you both get the diagnosis. Because you're pretty much guaranteed that it's going to trickle down to affect the other person. So when they got the diagnosis of ALS, at the beginning, the patient was very gung-ho of like, I'm going to beat this, I'm going to beat this, I'm going to beat this. He was extraordinary. He worked out. He was an athlete. He worked so hard at keeping his body as stable as possible for as long as possible. And his wife was very supportive as well. And the thing that I noticed is that it wasn't that she wasn't supportive the entire time. That wasn't the case. It's that there started to come a point, I want to say maybe like year 4. And for some people, it'll be much sooner than that. He just happened to really fight that disease like it was nobody's business. But around year 4, it started to really take a toll because his body started to like decline more and more. And his independence was going away more and more. And what I noticed was, even though you had a really truly loving wife, she started to get, the burnout was so massive. I mean, she would make comments like, I just need to be able to sit down and eat one meal, just eat one meal all the way through. Can I just do that? And, he would tell her, like, of course you can. But in reality, she had a point. His independence became, his entire world became dependent on her. Completely.
I'm sure that wasn't his choice, too, though, being an independent person.
No. Okay, so side note, none of the things that we're going to talk about are choices.
Right.
So the patient will never have a choice in these conversations. The caregiver will never have a choice in these conversations. These are conversations that are complex because 90% of the effort that has to be put in while you're in pain, while you have very low independence, while you are severely, debilitated by the disease. So yeah, no, obviously he didn't have a choice. What I see though is that he had a choice in how he addressed the level of anxiety that he had during the process. And I'm saying it as a therapist, I'm not saying it as someone with ALS. But his level of OCD and his level of anxiety became so overwhelming that he started to suspect that he would be urinating on himself even when he wasn't, and that was anxiety. He was so anxious that he might have an accident on himself that it was like, the second he thought he needed to go to the bathroom, she had to be there immediately. She had to drop everything. It didn't matter if she was in the bathroom or if she was taking a shower, if she was eating, nothing. It had to be dropped immediately.
So was he totally aware then of like when she would want to sit down and eat, was he aware that she wasn't getting to eat all the time?
Probably not. I mean, you're like, I doubt it. You've got so much in your own mind, anxiety from the disorder, but then too probably freaking out about the future. What is that going to look like? How long do I have? But then also like reminiscing on what I used to be able to do. I can't do anymore. Like, those are constant thoughts. So I don't think you probably did, and not in like a selfish way, even though it may look that way. But just there's no capacity left. So think about that.
She would tell him. She would say, can you hold on a moment? I need to go, I'm finishing up food or I'm microwaving. And I hold on a minute. And to me, when it was time for our therapy sessions, he would swear up and down that he did give her time. And that he would tell her, it's okay, take your time whenever you can. But on the other hand, when I was present without even realizing it, he would behave completely different than what he was saying. So he would be like, I swear I give her plenty of time. I just ask her politely to please like come and help me out whenever she has a chance, blah, blah, blah. And then I wait. But when I was just there visiting with them and he needed something, he would be like, so-and-so, where is she? Where's so-and-so? Well, why is she coming? What, like, I don't understand. Can she hear me? Like that.
Almost sounds like fear too.
Oh yeah.
Yeah.
So both parties were feeling like they weren't heard and they were misunderstood. Is that common for this type of a relationship?
Extremely. Yes. So what do you think the patient is thinking as far as communication and relationship in the relationship? What do you think is going through when the patient is hearing the caregiver say, you don't listen to me, you don't even give me a chance to eat, you don't care that I'm not even getting to eat, you just, all you care about is getting what you want. What do you think the patient is thinking?
Do you want to switch roles?
Okay.
That's my first thought. Would you want to switch roles? Would you want to deal with what I'm dealing with?
Do you think I want this?
Yeah.
Those are exactly the types of statements that you will hear.
Well, yeah.
And that's where it becomes kind of this horrible cycle of guilt and shame and guilt and shame and guilt and shame over and over and over. One person will at any point be feeling either guilt or shame at any point. It doesn't change. And then that person affects the other one and that other person's feel like it's constantly like that. And
that's where that burden role comes in, that they feel like a burden. That's the guilt. Even though it's not their fault that they have the disorder, obviously, but it's still, you feel like a burden.
So they feel like a burden, and then I wonder how is the caregiver feeling about their own personal lives at this point?
I have no life. That's what the caregivers think. I've heard anything from, and this was not just this particular person, overall, I've heard, I have no life. I thought I was going to get to retire and I'm never going to get to retire. I'm afraid that I'm going to die before my loved one does.
There's that guilt.
I'm afraid that I'm not going to be strong enough to keep taking care of them. But at the same time, I resent the fact that I am declining my own health because I need to take care of them. So there's that sense of I'm both afraid to place them in a nursing home because I've seen how they get treated, or maybe it's not a good situation, or financially they would have to put them in a place that would be very low quality. So not enough caregivers there, not enough nurses, no answers to call buttons, that sort of thing. So like afraid that if they walked away, that would end up happening. and they still have an attachment to that person. They still love that person. So it's either that fear, the fear that they might pass away first and nobody's going to be able to take care of them, or the resentment that, darn it, I am the only one. I am the only one doing this.
So what are some suggestions for them to maintain their own life control while still taking care of the patient?
Same. I don't know. I feel like in a lot of ways it's not exact, but in times I think it's similar to parents that are raising kids. You have the option to completely lose yourself in child care, or you can make something work. So you can't just make it all about your kids, right? Like you can leave your kids with someone. So it's about, to me, it would be about like allowing help. Like allowing, at times, hire, I know not everybody has the money, but like one night hire a nurse to come in for that night so you can go out with friends, or you can just go away and like breathe for a little bit, that kind of stuff.
Yeah. I would say there's a lot actually that both can do to go through the process in a way that doesn't completely destroy the relationship. From the caregiver's point of view, I would say the first thing that I can think of immediately is to do your best not to let yourself be sucked into the anxiety and into the fear that the patient is experiencing. That's the first thing right off the bat. Like, I call it the caregiver bubble, because people start to avoid phone calls, avoid visitors, they stop going places, they stop doing things. And sometimes it's because they have to, and sometimes it's because they also start to feel this overwhelming sense of catastrophe and anxiety and oh my God, and everything is horrible and we're having a terrible day, and to the point where any moment that could be a positive moment gets put to the side because you just can't afford to have it. So like the first thing for sure is acknowledge that the experience that your loved one is having is not your own experience. Acknowledge that in yourself and recognize that they're going through an emotional experience that may involve catastrophizing a situation. It may involve becoming obsessive compulsive. It may involve anxiety. It may involve depression. It may involve even panic. That's their emotional state. That is a subjective state. Like, you don't need to ride that roller coaster with them. If you can see clearly that the person is able to spend 15 minutes on their own, don't let the guilt put you in a position where you can't take a shower because, oh my goodness, I can't even leave them for 15 minutes. You know that you can leave them for 15 minutes. You know that it's okay. Every single time you don't reinforce the fact that it's okay, every single time you avoid taking that shower, you're reinforcing the anxiety, you're reinforcing the mental illnesses that are coming up from the disease. Every single time you avoid eating a meal, just because you need to feed into that fear and into the OCD, you are reinforcing that.
So it's going to make them more dependent. Whereas setting the boundary helps keep that deep independence, what is left, intact.
That brings to mind, for example, another patient who has been, he's been hospitalized and then put into rehab multiple times. When he is home, he cannot lift a finger. He cannot get himself a glass of water. He cannot get to the bathroom. He cannot walk more than 10 feet. He cannot sit in a chair on his own. He cannot, nothing. when he's home.
So just to clarify, when you're talking rehab, you mean like rehabilitation?
Rehabilitation, yeah.
For like an illness or something
Yes.
like that, not
Like you ended up in the hospital. You ended up in the hospital. Maybe you had COVID or you had the flu or you had pneumonia or you had a fall or something like that. You went to the hospital and then you were a little weak, so they sent you to rehabilitation for a while and then you get back home. He's had that happen multiple times. When he's home, he is incapable of doing most daily tasks.
So it's almost like learned helplessness.
When he is in the rehab, guess what he's doing?
Very independent.
He's very independent. Why? Because they don't answer those call buttons. Because you only get help to go to the bathroom when you've been waiting for an hour. So guess what? He has to learn to get out of bed and make it to the bathroom. He has to learn to figure out how to clean himself. He has to learn how to walk there or how to get in a wheelchair and get there. You know, he eats whatever they serve him. At home, that's not the case. At home is like a very manicured meal. So like
specific to his liking.
Yes, exactly.
Which to some degree, things like that should be happening because you are in your home, but it shouldn't you shouldn't completely do away with your own independence and ability.
So
it sounds like the problem comes from when it's impacting the other person in the negative way as well. Like you take care of the patient, but then it gets in the way of the caregiver.
Well, here's the thing. Most people at the beginning, has they kind of, and this is one of those things where like most of the time you become a caregiver, you don't even notice that you became a caregiver. It just happens.
So it's a subtle change?
It's either a subtle change or it's so sudden because the person had a stroke, because the person had a heart attack, because the person, got diagnosed with cancer. I mean, like, boom. Other times it's subtle, like, well, you've been experiencing depression for the last 3 years and we've been fighting this for the last 3 years, so it can be one or the other. But what I can say is if you allow it, like at the beginning you feel sorry, you feel the love and the empathy at the beginning. But people, if you give a person an inch, they are happy to take that mile. It is human nature. It is literally human nature to take what it is given to them. And at first it's a thank you. At first it's a, oh my goodness, I can't believe you're doing so much for me. And in the blink of an eye, it turns into, well, this is what you're supposed to do. This is what you've always done for me. Why are you changing now? Do you not love me anymore? Do you not care anymore? So that's why my first and top suggestion is learn to appreciate setting healthy boundaries, but more importantly, learn to appreciate not encouraging helplessness. That learned helplessness, learn to avoid that as much as possible. Like every single opportunity that you can to encourage your loved one to be independent, whether they like it or not, do it.
So what I've heard from you both is the caregiver should be making themselves a priority and not giving in to that learned helplessness behavior. What about from the caregiver's end? Is there any tips for them to not feel the feelings that you just stated of, do you not love me anymore and stuff like that? What are the suggestions for them to be in the relationship?
Well, this is something that we haven't touched on yet, and it's the psychological aspect of that relationship. To me, what I've noticed is every single symptom that I've described, whether it's anxiety, OCD, depression, the learned helplessness, which basically we're talking about codependent attachment, things like that. All of those things, we cannot ignore the fact that go hand in hand with psychological manipulation techniques. They all do. So understanding that like the person who is the patient now will subconsciously use psychological manipulation on the caregiver. They don't really know that they're doing it, but they will do it. they will do it because they understand that they have a need, and it starts to become one of those things where the need is stronger than the empathy for the caregiver.
Well, it's also their own depression and anxiety and hopelessness too can be being, again, someone, especially if it's like a terminal or like, you're not coming back out of this, like it's declining or it's set at what it is, you're not going to get better from whatever it is that they have. There's that hopelessness. So then like at that point, kind of that mentality like, well, who cares at this point? Like, why bother? Why try? Why any of that? And that's where the boundaries of like, no, you need to maintain somewhat of your independence the best you can is so important.
And then also, just so you understand one more thing too, is that most people don't have 24/7 to think about themselves.
Mm-hmm.
Most people have something going on in their lives.
Mm-hmm.
When you become chronically ill, or when you are mentally ill to the point where like your mental illness has taken over your day completely, you have nothing. You become hyper fixated on yourself. Everything that you have is just yourself. So you will monitor every breath you take, every movement you make, every ache, every ick, everything becomes the most important part of your day. I tell this to my patients a lot. I'm like, this is what happens when you have no dragons to slay. You have no tasks to complete. You have nothing when you've given up, like Stephanie was saying, when you've given up on any kind of life goal or any kind of self-growth or development goal whatsoever. All you have is yourself, and you become the center of the universe. So those psychological manipulative behaviors are center of the universe type of behaviors.
I think they're a way to seek comfort though too, because it doesn't stop the inner turmoil and depression and anxiety that the patient has, and so it's almost like a subconscious way of seeking comfort. Like, if they make me enough meals, give me enough attention, do enough of this, enough of that, my discomfort will end, whether that be because of the illness or just psychological or emotional. But that's not the case. But it is the same gambit that I think humans in general we run into. We think if we have enough of XYZ, something outside of us, that's going to make us feel better.
Enough. I have a patient that collects bottles of waters next to his bed.
Yeah.
Or if I have enough bottles of nose spray,
seeking comfort
at any point in time. If I carry enough tissues in my pocket.
You bring up a good point. You mentioned control. So likely they're all trying to find some control of their own lives because does the illness kind of take over?
Mm-hmm. They're trying to find control of their lives, and they're trying to also find control of their environment. So since the caregiver is part of their environment, then they're also trying to control the caregiver.
Yeah.
Subconsciously.
Mm-hmm. Yeah. This is not done maliciously.
Yeah, like it's not a choice.
Nobody rationally thinks, I don't have control, so I'm going to control this person and make them miserable. That's not how most people think.
Yeah, no, it's not done maliciously. It's not done on purpose. It just becomes this terrible cycle where the needs are being expressed all wrong, and the comfort is being sought all wrong, and you're so caught up in it that you don't think about, well, let me see how I can do it differently. It's more of like, let me just follow my instinct, and my instinct is to seek the comfort in the first way. And mind you, thinking about this too, the way the caregiver acts has a lot to do with the way that they were brought up themselves. The way the patient acts has a lot to do with the way that they were brought up as well. If you have a person who was brought up emotionally neglected, they will be a very needy patient. Very, very codependent patient. If you have a caregiver who was brought up neglected, they will be a very burned out caregiver, very feel a lot of resentment because they were not brought up being taught how to be gentle and caregiving, because that's not their upbringing.
So as the therapist, you recognize that all of their behaviors serve a function. So is it when you're helping them, are you trying to help them find alternative ways to serve that same function that's not going to harm each other?
When they're open to it, yes. That's the goal, I think.
That's why I think that's part of the how do you prep for this life, is that the patient and the caregiver should both get counseling. And I think especially early on for the person that was diagnosed with whatever it was,
my goodness, yes.
because that's before they've lost the hope, before they've become dependent. They can already be in counseling, learning ways to keep their independence, and then working in tandem with the caregiver, getting counseling, saying you need to keep your independence. It's like you can set those boundaries early on.
Mm-hmm.
Would you recommend they seek counseling together or as individuals or both?
I think probably both.
Mm-hmm. Individually, definitely.
I think definitely
Yeah.
individually, because remember, you're touching on some points that may be hurtful to your loved one.
Mm-hmm.
You know, so things
And
like
the caregiver, another thing of like needing that space to themselves. That counseling is a space for just them to maybe say some, very nasty things about the patient that they need to get out.
Or about themselves.
Or about themselves.
Because the patient may be like, I'm going to be honest, I don't want to be alive.
Mm-hmm.
Like, I don't want to live. But I don't dare to say it out loud because I know my wife or my husband or whatever, my significant other, bursts into tears and starts to feel like it's their fault
Mm-hmm.
if I do that. So I have had patients that will sit with me and they will tell me, I don't want to live anymore.
Mm-hmm.
But I would never say that in front of my loved one.
The caregiver probably doesn't want to share how they're feeling either to the patient because
Well,
you have it so much worse. Why would I add that burden to your burden?
Well, and they're painful truths, but they're not necessarily ones that need to be spoken because they're just going to hurt.
Yeah.
But so they need that space to be able to say those things out loud.
Yeah. And something that I found that is, it just makes a huge difference when you seek the help together then as well, is that what you really want more than anything when you're seeking help together is as education.
Mm-hmm.
Like, most of the time, these diagnoses come out of left field. Like, people get diagnosed with ALS, kidney failure, cancer, things like that. They are not the types of diagnoses that you are prepped for. These are the types of diagnoses that you had no clue that your body was going through this, and all of a sudden you end up in the hospital, and guess what? You have 3 years to live.
Mm-hmm.
Like that. So most of the time, the patients have no idea. They've had very little experience with family members because they don't know anybody that has had ALS or dementia or cancer.
Mm-hmm.
They've heard about it, but they don't actually know anything about it. So, like, you want to be part of a group. You want to, like, immediately, as quickly as you can, get on a group chat, join an organization that supports what you're going through. There's tons of organizations for different chronic illnesses out there.
Nowadays, it's like so accessible. There's
Mm-hmm.
Facebook groups for people that have different stuff. There's Facebook groups for caregivers of people that have different diseases and mental health issues and all of that.
Yeah.
Is there anywhere they can go to find like local resources for like in-person groups or anything like that?
It completely depends on the diagnosis. Completely.
And the location.
Yeah.
In-person groups are hard to come by.
In person is a little bit. Yeah, in person is a little bit more difficult. There are popping up here and there, but it really depends on, like, for example, if you have, I know, like, if you have Alzheimer's, there's like 50 million ways that you can get support.
Mm-hmm.
I know that. If you have ALS, there's 20 million ways that you can get support.
Mm-hmm.
But on the other hand, if you have kidney failure, you'll get a lot of support for transplant, maybe not so much for mental health.
Gotcha.
So I was doing a lot of work when I worked in dialysis. I was doing a lot of work for the mental health side, like support groups and stuff like that, because there weren't any in the community. So like, it really depends. But find it, because it will be out there somewhere. It doesn't matter if you're Zooming it, if you're in person, however the heck it is, but find your people as quickly as you can and get yourself with a therapist who can talk to you about, even if the therapist doesn't have a ton of experience with that particular diagnosis, you can go to the resources and say, this is what we know might be coming. How do we work together as a couple to figure it out? How do we work on our communication? Like, you can tell the therapist, here's the information that we have. What do you think we can do as a couple? Because we want to preserve our relationship, because that's the most important thing for us.
So have them bring their fears to the forefront to discuss moving forward. Kind of set yourself up before.
Yeah.
Yeah.
What would you say are some of the things that clients can do to preserve their relationship? Like patients can do to preserve their relationship with their caregiving partner?
I mean, it's still, I think one of the biggest things is the same they tell you in every relationship of like, you have to somewhat keep making it like you're dating each other. So like quality time together. That's not caregiving. It's sitting down, it's playing a relationship game, or it's the caregiver maybe making the meal or ordering a nice meal, but actually like light some candles and sit down and be intentional with the time that you're spending together.
Absolutely.
And make it not, again, about the caregiving or the disorder or anything. Like, just even for, if it's an hour, like pretend like it's just you guys on a date and that this whole mess is not going on right now.
Yeah.
Because you are still people outside of that. Even the patient is a person outside of the disorder that they have. And so they need to be reminded of that too.
Mm-hmm. Yes, that's a big one. You're right. Because the patient, like I said, the whole world becomes their body and their mind. Like the whole world. There's nothing else beyond it. Sometimes their whole world is a wheelchair. Sometimes their whole world is a bed. And they lose themselves. So I think I have a thought too for patients. Try to get interested as much as you can on still doing some things that keep your identity. You may not be able to have the same identity you had before the diagnosis, but you can still find things that may give you pleasure, and you may reinvent your identity under the conditions that you are. And a simple, very, very simple example is like reading. There's so many different ways to read these days. You can do audio reading if you can't use your hands. You can have someone read for you. Like the library has a talking books thing, but you can do the audio where somebody's reading the book for you. You can do the library talks. You can do an actual book. You can do Kindles. You can do whatever. But reading is a big one. Brain games is another one. Things like playing chess online is another one, where you can actually talk to people that you're playing across the world with and establish a relationship, and you still are just home. But get your mind busy with other things. Because if you're housebound but you're able to use your hands and stuff like that, send support letters to the troops or to people who are living alone, or there's nonprofits that connect people who are living alone. For pen pals, there's a pen pal nonprofit. So there's things that you can do that you can still have some quality in your life that will help you get yourself out of your own mind, so that then you can have a better relationship with your partner, because then it's not just everything's about me and what I'm experiencing. It's oh no, I have purpose.
Mm-hmm.
You've talked a lot about when people get those physical diagnoses, but you touched on too when people are diagnosed with depression and stuff like that, and where that change may be a little bit more subtle, and it's not necessarily the diagnosis that would be the trigger. Do you still see some of the same patterns between the relationships?
Yes. You can do, yeah, at least I do. You can do neurological. So, for example, dementia.
Yeah. I'm thinking like when it's just depression.
You can do depression.
Like when you have a partner that the depression's so bad that they all of a sudden now it's been 2 years and they don't work anymore and they can't hardly get out of bed. They don't upkeep the house, nothing. That I feel like same somewhat, but I feel like sometimes a little bit of the pressure is taken off because it's not necessarily in the same way of like ALS and where like you're having to help them maybe get dressed or feed them, like it's not as manual of a caregiving task.
But I will say, and again, that goes back to the caregiver, I have to admit this.
Mm-hmm.
I will say it can very easily become so emotionally taxing and so physically taxing when you take on the role of both the partner who does everything in the house plus the caregiver as well.
Mm-hmm.
It can be so taxing, and it does go back to how much in terms of boundaries do you do, and this makes me think of kind of a controversial topic. So this is the last thing, and it's so this last thing,
but it's a doozy.
It's a doozy. I'm sorry, I like to talk about these things, but yes,
you on your toes.
This is a doozy, and ending the relationship.
Mm-hmm.
What like when is there a point when you say, I can no longer be in a relationship with you?
Mm-hmm.
And how does the caregiver feel about that? And how does the patient feel about that?
Abandoned, and the caregiver feels
Guilt. Horrendous
At the
guilt.
same time, probably freedom and relief, but then that will also bring more guilt.
So for a patient, they might look at it, I think, almost like a death sentence.
Mm-hmm. Yeah.
For a caregiver, staying in their relationship may feel like a death sentence.
Mm-hmm.
So I do have to admit, even though it sounds maybe heartless, there are points in a relationship, and I know this is a hot button topic. I know this because a lot of people are going to be like, no, till death do us part, or no, like how heartless would you have to be? But let me put it to you this way, and this is me representing caregivers. But let me put it this way. If the person has gotten to a point where they don't care about themselves or you, because they don't care about themselves so much that you are irrelevant at this point. Your feelings are irrelevant, your needs are irrelevant, your emotional state of mind and physical state of mind is irrelevant. All they are consumed by is their pain. Psychological, emotional, physical, all they can think about is themselves and their pain and their situation. That's it. That's their entire life. At what point do you still have the right to say, I need a life jacket. I need to also get myself out of a situation where I'm literally, I can think of a caregiver right now who's had a stroke, who has high blood pressure, who has diabetes, all happened within the last 5 years. I don't know if you can say 100% of it came from being a caregiver, but I can definitely tell you a huge percent of it did.
Mm-hmm.
Because the level of stress, the physical exertion, the amount of just emotional strain all the time. This person is a full-time caregiver. They're the only ones who give them baths. They're the only ones who feed the person. Everything is on them. So their back is shot. And this patient didn't marry someone that was 30 years younger than them. They're the same age.
Mm-hmm. I think that's why it's so important, like you said before, to set the boundaries early and make yourself a priority early.
Well, I think because with or without a disease, you can do things to help yourself.
Yeah.
And it's like, I understand there are, yes, some diseases that you can't help, you know, MS, ALS, all that kind of stuff. Like there are certain things that the body's just literally not going to be able to do at a certain point.
Mm-hmm.
But that's not saying that there isn't stuff like counseling or groups or, you know, just even little things that you still can do around the house. It's that difference between like giving up.
Yes.
Or I am not going to give up on myself. So
Yeah.
then you're more likely to have a partner and a caregiver that is going to say that I'm not going to give up either. But why should the caregiver keep caring when the person that they're caring for has given up?
Yes.
On self and everything else.
Completely.
Yeah.
So and that goes back to another reason why it's so important to reach out to resources.
Mm-hmm.
That's another reason why. Talk to your church group if you go to a church or any sort of religious organization whatsoever. Friend groups, social
like
groups.
Because sometimes
neighbors.
depending on what you have, like ALS, MS, you're going to specialty doctors.
Yes.
A lot of times you're going to specialty hospitals. They can connect you with like,
Support.
oh yeah, here's a support group for this and that, and that, like that stuff's out there, but you just have to find it sometimes.
Yeah. And that's important because another thing that also, like, it prevents the burnout for a little bit longer. It still gives you a chance to have a little bit of independence as a caregiver. You can still do more things on your own, which gives you the strength to continue going. For example, isn't it so much better when a person can afford to go to their appointment, their personal appointment, so that they can take care of their health, you know, rather than not even being able to afford to go to their own personal appointments. I know countless caregivers who their loved one passes and they finally make it to the doctors and they have so many things wrong with them. And they're like, well, it's been 3 years since I had a checkup. And this is someone who's in their 70s, 80s. I mean, we're not talking about young people. We're talking about 60s, 70s, 80s. And it took you 3 years to make it to your primary care physician.
Mm-hmm.
You know, so if you have resources in place, even whether it's a family member, a friend, a neighbor, don't be shy to like ask for an hour, 2 hours, you know, something, so that you can go and take care of yourself. You know, and another thing that also adds to that is whenever the patient has people in the house and there's socializing that has to happen, you have to stop thinking about yourself, even if it's for a few minutes. Because people come and they want to play a game with you, or they want to watch TV with you, or they want to have a conversation with you, want to have a meal with you. At least for those few moments, you are not your disease. You're with friends. So that also helps.
Mm.
So let's see, before we wrap it up, anything else? Any other suggestions? Any other thoughts? Before I think of another bomb.
No, I think that really encompassed a lot. It's just understanding the patient needs to understand that they are not their disease. They're still a person, and the caregiver
needs to understand the same thing.
Right.
They are not just a caregiver.
And the patient is not their diagnosis, too.
Yes. Yep. Exactly. Yeah.
So that's it for us for today's episode of Between My Therapist and I. As always, feel free to share, comment. If you have a story of your own experience as a patient or a caregiver, feel free to leave us your story. If you have more questions, if there's anything else you'd like us to talk about, any other topics, share that with us as well. We'd be happy to do it. In the meantime, we thank you and we hope you have a wonderful Friday.
Bye.
Bye.